So, you're at your shift at the emergency department when a 26-year-old male arrives. He's complaining of chest pain just below the sternum that's persisted for most of the day. He describes the pain as constant, localized, and it feels like his chest is being squeezed. As you begin to take a health history, you discover the patient is stressed. He has been experiencing palpitations, shortness of breath, and spontaneous diaphoresis, otherwise called sweating. The patient feels anxious and reveals that they've been using cocaine every day for the last 6 days, and last used cocaine 24 hours ago. To relax, the patient has been drinking tequila for the past 24 hours. Other than these recent events, the patient has no significant health history. Vital assessment shows that the patient is tachycardic, hypertensive, hyperthermic, and is hyperventilating. Physical examination only reveals dry mucous membranes and tachycardia. So, we draw blood and see both troponin T and troponin I are elevated, but nothing else is out of the ordinary. Since our patient hasn't been complaining of severe knife-like chest pain and blood pressure isn't critically high, it's reasonable for us to rule out aortic dissection for now. Actually, we recently made a video on aortic dissection, so click the box above to check it out. The differential diagnosis is long, but our patient, unsurprisingly, has cocaine-associated chest pain. Cocaine use, even casually, can cause acute coronary syndrome.
The big thing with cocaine is that the way it works is it increases our flight or fright responses, it increases our sympathetic activity, and it increases the amount of adrenaline we have in our body, noradrenaline we have in our body.
Dr. Sanjay Gupta is a consulting cardiologist at Nuffield York Hospital, and he's discussing cocaine-associated chest pain on his YouTube channel.
Now, the problem with this is that when you take adrenaline and noradrenaline, one of the things that does is it increases our heart rate. So our heart rate goes up and our blood pressure goes up. But also because of this vasoconstrictive property of cocaine, our blood vessels tighten up. So our heart takes a double whammy because A, the heart is being expected to do a lot more, beat much faster, the pressure has gone up, the heart has to work much harder. But at the same time, by constricting the blood vessels, you're actually stopping the blood from getting through to the heart muscle to support this increased activity.
This is because cocaine inhibits norepinephrine reuptake, causing an increased sympathetic nervous system response through stimulation of alpha and beta adrenergic receptors. Cocaine also causes hypertension, coronary vasoconstriction, coronary spasms, and premature atherosclerosis, which can lead to other complications like aortic dissection.
The other thing that then does is that when you have that situation, blood isn't able to get through and the blood can then stagnate and blood clots can form, which make everything worse. So cocaine is terrible in the acute setting for the heart and the pressures it puts on the heart.
For this patient, we want to find out if he's having a myocardial infarction. So let's see his electrocardiogram. What do you see here? The electrocardiogram shows a heart rate of 150 beats per minute, although it's hard to say if this is sinus tachycardia or atrial flutter with a 2-to-1 conduction. The deflection is negative in lead 2, which suggests an anterior fascicular block. There's a right bundle pattern present in V1, but this isn't present in V2, which points to the anterior fascicle again. As for the ST and T wave segments, there is no ST elevation, and all the T waves point in the direction they're supposed to. Okay, now that we have a pretty good idea this is cocaine-associated chest pain that has not caused plaque rupture, how would you treat the patient? Patients with routine cocaine use can present similarly to patients with pheochromocytoma. The constantly high levels of catecholamines like epinephrine and norepinephrine lead to volume contraction. So despite having high blood pressure, they're almost always hypovolemic. This volume contraction increases vasoconstriction, further reducing organ perfusion. So be sure to include rehydration therapy as part of your treatment. And to counteract unwanted platelet activation, you can give aspirin, just like in acute coronary syndromes. We hope you enjoyed this case. Thanks to user Josh1010 for posting this case on the Figure 1 platform, and for everyone who participated in the conversation around this case. If you want to continue discussing this case or want to check out other cases just like this, sign up for a free account on Figure 1 and join our growing community of health professionals sharing their learning experiences.